Hello, and welcome to our webinar on co-occurring conditions and Tourette. My name is Ali Gemma, CDC Program Director, and I will be your moderator for the webinar. This webinar is being provided as part of the Tourette Health and Education Program, a program of the Tourette Association of America in partnership with the CDC. During the webinar, we will be very happy to hear from you and include your voice in the conversation. You can ask questions or share comments using the question panel on the right side of your GoToWebinar player at any time. We will collect your questions and address them during the Q&A session at the end of the presentation. Additionally, you'll note that we have a handout of the slides that you can download from your control panel and will be discussed in the presentation. I want to mention that funding for this webinar was made possible by our cooperative agreement with the U.S. Centers for Disease Control and Prevention. The views expressed by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply the endorsement by the U.S. government. It is my pleasure this evening to introduce you to our speaker, Dr. Marty Franklin. Dr. Franklin is Associate Professor of Clinical Psychology and Psychiatry and Director of the Child and Adolescent OCD, Tics, Trichotillomania, and Anxiety Group at the University of Pennsylvania School of Medicine. So without further ado, welcome, Dr. Franklin, and please go ahead with your presentation.
Thanks so much. Good evening to everybody. Just by way of very brief introduction, I'm a clinical psychologist and run the Cottage program, and in the context of Cottage, we see a lot of kids with OCD. We also see a lot of kids and adults with Tourette's, and we are dealing every day with the co-occurring conditions in the context of treating Tourette's. So that's what we'll be talking about tonight. I've tried to make it very clinically focused, though I'm happy to take research questions for those who might be interested in such things. So let me start off first by, if I could advance my slide. There we go. First things first. So I'm going to cover a couple of things in the first half hour. These are the presentation points I'm going to try to hit on, and then of course we'll have ample time for questions afterwards. I'm going to really talk about the co-occurring conditions, what you might expect to see when you're treating kids and to an extent adults with Tourette's. And then how we approach those conditions in the treatment process, treatment decision making, and also treatment implementation. And I want to address some common misconceptions about these co-occurring conditions because I think they can impede progress and reduce optimism, which certainly is something we want to make sure we're not having happen in our treatment. So that's what we're going to be talking about. Very first thing I want to point out is the importance of proper assessment, because you really can't fight what you can't see. So a comprehensive evaluation, both of tics and also of co-occurring conditions, is crucial to help you make decisions and also to teach the family and the child too what it is that we think is going on and how we're going to address the various pieces that are occurring. A decent analogy, maybe in the midst of the American and National League Championship Series, is scouting. So if I'm trying to formulate a plan or make decisions about what's going to be best, I have to have information about what's occurred in the past. I want to have a lot of information available to me about current severity and co-occurring conditions, and I want to really be aware during my assessment, looking directly with my own eyes at what I'm seeing in terms of symptom severity, in terms of interaction amongst family members about tics, interactions amongst family members in general. All of that's going to be grist for the mill when I come up with decisions and plans about what we're going to do treatment-wise. So when I'm addressing tics in kids, I certainly want to use diagnostic structured interviews, which we certainly have, and we'll talk about them briefly. Also self-report measures, which are a little bit easier and sometimes provide us complementary information. Parent-teacher reports and measures I think are important to consider. And I also would emphasize your own direct observation. The minute I walk to the waiting room, I'm already getting information that I may not get from any of those other sources about what's going on with the kid, how everybody's handling it, and what needs to be addressed based on those observations as well as the data we're gathering during intake. So in terms of assessment instruments and strategies, I'm going to just walk you through quickly some of the typical ones we use and why we use them. So the clinical interview for severity is something called the Yale Global Tic Severity Scale. Jim Leckman and colleagues at the Yale Child Study Center created this and have worked with this instrument for really many decades now. It's administered by a trained clinician. We don't usually use this one as a self-report because some of the concepts are a little tricky. And we're looking at the number of tics, we're looking at tic frequency, intensity, complexity of tics. So are they just simple tics or are there series of tics? And also functional interference and scores for both motor and vocal tics. We recognize that in some kids you're only going to see motor or you're only going to see vocal. When we see both motor and vocal together, we're diagnosing Tourette's, but we also think chronic motor or chronic vocal in the absence of the other can be just as impairing and really worthy of treatment. So the diagnosis of Tourette's per se it really has to do with the presence of motor and vocal tics and not really so much with severity. There are also self-report instruments that we use. One we really like to use is the premonitory urge for tic scale. This is out of Doug Wood's lab and work. Really gives you a sense of whether the kid can identify what we call the premonitory urge. So the physical feeling, usually at the site of the tic, that happens right before the tic occurs. We want to know if they're aware of it. We want to know if they resist it or have any perceived control over it. That also can influence our decisions in treatment. The younger the kid in general, the less aware they're going to be. So if I have a 5 or 6-year-old in my office, as I often do, they may have no awareness of the physical urge to tic. They just do the tic and they can't tell you much about what preceded it, which complicates treatment and has some implications for us too. We want to get parent tic questionnaire in there as well, just to make sure the kid is providing us some information that only they have, and the parents are also, especially when you got a kid with tics, you're watching them pretty carefully, and that information can be really valuable to round out the assessment. So the Yale in a little bit more detail, because it's probably the key one. It's a semi-structured interview conducted usually in 15 to 30 minutes, maybe 30 minutes the first time, and as you're repeating it, you get to know the kid and they get to know the instrument. Tends to go a little quicker at that point. As I said, motor and phonic tic scores are separate. There's a checklist, a very detailed checklist of tics. There's severity rating scales and also impairment scores, which will help drive your recommendations. It's a rating scale of 0 to 50. It's extremely rare to see anybody with a 50. Obviously, it's extremely rare for somebody in a tic clinic to have a 0 as well. Typical pre-treatment score in the randomized controlled studies that they're looking at medications and looking at psychotherapies for tic disorders, you typically see people coming in the low to mid-20s on this instrument. That gives you a sense of clinical severity. So what are the most common, I'm using the term comorbid as opposed to co-occurring simply because it's shorter. But the common comorbid diagnoses and clinical presentations. When you're looking at kids, one thing I would say is if I'm looking at a 5-year-old, typically I may be looking at probably tics alone or tics plus ADHD. Some of these comorbid conditions will come upon later, late childhood or early adolescence, which we'll get into. But in terms of the ADHD and ADD comorbidity, that is the most common psychiatric comorbidity. We're talking in lots of studies that have been done over the last several decades, anywhere from 30 to 70% of kids with tics are going to have a comorbid diagnosis of ADHD or ADD. Another very commonly co-occurring condition is obsessive compulsive disorder. And in that case, what we're looking at from multiple studies is anywhere from probably 30% to 50% of kids with tics also have a co-occurring diagnosis of OCD. Other anxiety disorders besides OCD, OCD used to be considered amongst the anxiety disorders, has its own category now, but certainly anxiety is at the core of OCD in most cases. But there are other anxiety disorders such as social anxiety and generalized anxiety disorder, which also co-occur with tics. About 20% in a recent study of kids with tics had comorbid anxiety disorders, GAD, and social phobia or social anxiety disorder. Mood disorders are not quite as common as the other ones, maybe 10% in the samples I've looked at, but it's certainly something you want to pay attention to as you move through late childhood and into adolescence. The mood disorder diagnosis pops up more frequently, and if you're having a lot of functional impact and teasing and other problems associated with tics, you may well see those mood symptoms more prominently in kids who have those presentations. It looks like by the time you're looking at adolescence, the comorbidity, having at least one other disorder, may be the norm, especially as you're moving from childhood to adolescence. And some of the case complexity may be directly related to the tics. As I mentioned before, the mood disorder symptoms could be resulting from the problems associated with tics, whereas some of the co-occurring conditions seem like they're more related to development and typical disorder onset. So you may just be running into social anxiety disorder around the early to mid-teens as you might otherwise. But certainly there's going to be some enhanced sensitivity to social concern and social attention in the context of tics. So that may raise the base rate for kids who are starting to head into adolescence. So these are the more common ones. Certainly you can see many other conditions as well, comorbid with tics, but these are the most common. And we use assessment instruments and strategies as well. Sometimes we use a structured interview for OCD because it's so commonly co-occurring. Something called the SIBOX, the Children's Yale-Brown Obsessive Compulsive Scale. There's some self-report scales that we use as well to pick up on OCD, the presence of OCD symptoms and their relative severity. ADHD, we prefer to diagnose that across multiple contexts using a comprehensive evaluation. The CBCL and the CPRS are instruments that may well pick up on some of that in addition to the comprehensive evaluation. So we want to be on the lookout for it because we know that ADHD is the most common comorbid disorder. Depression, we often use the Anxiety Disorder Interview Schedule, which includes modules on depression. We use the Kid Mini, which is a short version. Gives you a quicker sense in clinical practice of whether there's comorbid depressive symptoms, and there's a self-report instrument for kids and adolescents called the Children's Depression Inventory. We use that as well. When we're looking for those other anxiety disorders, we use the ADIS, as we mentioned above. We'll also use the MASC, which is a self-report instrument out of Duke. John March is the lead author there, and it surveys other anxiety disorders pretty comprehensively. So in terms of doing the assessment, when you're talking about tics in front of the kid, it does not surprise us. Work out of Doug Woods' lab shows us that tics are responsive to discussion and verbal description. So if you start talking about tics, you may well start seeing more tics because of a suggestive quality to them sometimes. So you have to keep that in mind when you're doing your assessment. Sometimes you want to see the tics, but sometimes you have to pay attention to the context. So if the kid is living in a family where ticking is negatively responded to by parents, you may want to do that assessment of tics when you're talking about tics with the parents absent, if that's already a problem in the family environment. And will the kid be able to talk honestly about the tics in the presence of the parent? The younger the kid, the more likely I am to interview the kid in the presence of the parent. When they start to become late childhood, early teen, I tend to want to read that one a little bit flexibly. But late teens, almost always, they prefer to do the interview and the discussion in the absence of parents for obvious reasons, independence and embarrassment sometimes too. Keep that in mind. So when you're going through this, diagnosis, sometimes you're looking at behaviors that could either be tics or be compulsions in the context of OCD. I want to really try to dig at what's the prompt. And again, if I'm talking to a late childhood or adolescent patient, I'm probably going to get better information on this. So if I ask them, why do you do your tics? And the kid may tell me because I get a feeling in my neck right before I do it, and it's really uncomfortable, it feels painful, and I want to get rid of it. They're telling me that about it being more of a physical prompt. If I ask somebody about the exact same behavior and they say, well, the reason I have to move my neck that way is to prevent something bad from happening, and if I press them and say what bad things might happen, they say it could be anything. Bad things happening to my family, bad things happening in the world. That's more of a cognitive experience. And so I'm much more inclined in that case to think about that behavior as a compulsion, even though it looks the same. The younger the kid, the less insight you're going to have, and they're going to have probably less insight in knowing what causes their tics. So I'm going to need to get some information from parents and from other assessment instruments to sort that piece out, because the kid may not even know at 6 or 7. So I get my assessment complete. I'm looking at the tic severity and context when tics are more likely. I'm looking at how much functional impairment is there, and I've also now surveyed for the presence of comorbid disorder. So what am I doing next? Well, I'm needing to make some decisions about where I'm going to go in treatment and why. So this fork in the road idea is going to be based on the information I gathered, and we'll talk in some detail about how we make these decisions with families and with kids. So when we're doing treatment planning, we've got to take a number of things into account. First, we've got to look at those clinical severity ratings and impressions as well that we formed, both of tics and of the comorbid conditions. I want to know, if I can, where the dysfunction's coming from. What's driving dysfunction? What is this kid most bothered by? What gets in the way the most? If I have a parent and teacher perspective on that, I want to pay attention to it and take it into account, but I don't want to have it trump the kid's perspective, because ultimately it's the kid. If you're doing behavior therapy, the kid's going to be the one doing the work. And so I want to make sure I'm continuing to take their opinions into account when we make decisions about what to do. I want to look at that outcome literature and look at predictors and moderators of outcome to make sure if I'm choosing a path, I want to choose a path that I think is going to be successful. And I think that maybe most commonly where that comes up is if I have severe undertreated or untreated ADHD, and I have a choice, I see the tics are prominent, but I see the ADHD is going to interfere with their capacity to learn and do behavioral interventions for tics, I may need to go after the ADHD first, just based on what the literature tells us, which is that severe ADHD is often compromises outcomes for some of these interventions. So I have to make that point when we're discussing what to do. But child-adolescent preferences and motivation. Motivation is crucial. So what does the kid want to work on? What do they think the worst issue is here? And how motivated are they to do something about it? I have to take those preferences into account because I want to maximize their active engagement in the process, because really they're the prime mover. We're coaching and they're on the field, so I need the person on the field to be motivated to do what the coaches are telling. Okay? So when we're dealing with co-occurring disorders and symptoms in treatment, once you've made a decision to either treat ADHD first, or to treat OCD first, or to decide to treat tics first, I've got to still take into account these co-occurring conditions and how they're going to affect me. And the analogy I came up with here is sort of like if you're playing goalie and you've got a bunch of people in front of you screening you, you can't see the shot, it's going to make it more difficult for you to make the save. So we're going to have to make sure that we are, to the extent that we can, keeping the sight line clear. If we're going to treat tics first, we got to make sure we're handling the other issues in a way that the kid can successfully participate in whatever treatment we're doing. And sometimes if I feel like I can't do that, sometimes there are pharmacotherapy options that might treat more than one condition. And so we may want to take those things into account as well. But when we're talking about behavioral therapy, it's really very much about teaching. I'm going to try to do CBIT, the Comprehensive Behavioral Intervention for Tics, that's recently gotten a lot of good press and a lot of good scientific outcome data behind it. If I'm going to try to do that, I want to make sure that I can do that as effectively as I can, and not be interfered with, if you will, by the other conditions. A couple of different ways to think about this. If I'm looking at a kid who's got 2 or even 3 conditions, I may want to go after the one that's associated with the most functional impairment and tell them, I recognize we have these other things as well, but let's see what we can do on getting the biggest problem out of the way, and at that point see what's left. There may be some conditions, I think OCD and Tourette's in particular, where you could possibly consider yourself doing 2 birds with 1 stone, because there's so much overlap in what we're telling people about the behavioral intervention for tics as opposed to OCD, that they might be able to pick up and use the same methodologies for both. So I want to, and that may take a sophistication, probably an older kid. The other approach with I think younger kids, or with kids I think they'll have some trouble doing what I just said, is a bird-by-bird approach, one by one. Let's take one, let's focus on that, let's take the next one when we have time to do that. And when it comes to treatment sequencing, I'm choosing my targets, I'm choosing my treatments, and I'm evaluating how I'm doing. So I have an idea based on literature of how much symptom reduction I might expect to see, how much compliance I might expect to see by a particular period of time in treatment. And if I'm on track, I stay with it. If I'm off track, I'm not seeing any reductions, I'm seeing the comorbidity getting much worse, I'm seeing the targeted symptoms not going down, then I have to consider going back to the original plan and thinking, is this the right way to go with this particular kid? I'm going to be brief here about this, have a reversal idea, and just so I'm using it sort of as an example of how things might interfere if you're dealing with comorbidities. So the negative reinforcement hypothesis of tic maintenance, which is central to the CBIT idea, is that there's a premonitory urge, some physical feeling that occurs before the tic, and that gives rise to the tic itself, this discomfort and a negative reinforcement process whereby the person's uncomfortable, they do the tic, and lo and behold, they get relief from the physical feeling. That urge goes down even temporarily. And by going down, it's providing what we call negative reinforcement, the removal of discomfort, if you will, in this case. And that's going to maintain the tic, because the next time you feel that urge, you're going to want to do the thing that got you some relief before. And so the tics can be maintained by the elimination of the urge or the reduction of the urge. Elimination may be a little bit overstated. And there's a biological process underlying that urge and the reduction that we don't fully understand, to be perfectly honest about it. Now, if that is indeed the case, if negative reinforcement is a big part of why tics are maintained, even if it's not why they're caused, I need to interfere with this relationship here between urge and tic. So that's what I'm going to try to do. My intervention is designed to break the connection between urge and tic, which may well create some habituation or reduction of the urge over time. Maybe not immediately, but over time. And when I lose that source of relief, I may be able to weaken these connections, and that's going to serve me well. That's what CBIT basically is. CBIT, multi-component treatment, started a very long time ago. They've been adding components to it, but they used to treat tics primarily. 4 main components. First is awareness training, getting the kid and the parent to be more aware of when the tics are occurring, and even better yet, before they're going to occur. So what situations and what physical feelings are predictive of tics. So we can do what we call competing response training, which is doing something else instead of reinforcing the tic. Social support is a big piece of that, reinforcing the kid for effort, creating a tic-neutral environment, so we're not providing a lot of negative attention to tics, so we're really trying to ignore and go about our business as best we can. And function-based interventions, understanding better what the external contingencies and what force they have in influencing tics, either positively or negatively. So the implications of the co-occurring disorders for using CBIT. If we're going to use CBIT, which at this point as a behavioral treatment is the treatment of choice for tics, how can these co-occurring disorders get in the way? That's what we're going to be looking at. And there's a few things that we want to consider. First is treatment outcome expectancies. We already know that severe ADHD can impact the outcome of CBIT. And if you think about how that might occur, it could very well be that it interferes with learning. Because if I'm trying to teach a behavioral intervention to a kid, and they're climbing my bookcase and unable to attend, and they're looking at the magnets in my office, and they can't hold attention long enough to learn, then that may well be the mechanism by which that ADHD is interfering. So I have to pay attention to what I need to do there. So those outcome expectancies are influencing what I'm going to be choosing. Predictors of outcomes, moderators of outcomes, we won't split a lot of hair on that, but basically the bottom line is, if there are things that I know are going to interfere and get in the way of my teaching CBIT, I need to take those things into account. If you think about comorbid depression, for example, a kid whose depression is primary and they're really unable to conjure up much enthusiasm for this intervention or much else, then that may well lead me to make a decision, even though the tics are prominent, even though they may well be causing the depression, I may wish to go and treat the depression first because I already know that their compromised compliance is going to compromise outcomes. So I want to try to get the thing I think out of the way that could be leading to that compromise. And so really setting up the treatment expectations based on the extant literature. If you know the literature well enough and you've made a decision to treat the tics primarily or the ADHD primarily, you have expectations based on literature of how well you should be doing and by what point. And if you're getting, if you're 5, 6, 7, 8 sessions in to CBIT and you're right on target, then you can kind of stick to your guns and deal with the comorbidities later. If you're not where you need to be, you're 3 sessions in and the kid doesn't understand any of the core concepts whatsoever, and their oppositionality or depressive symptoms are really the main thing parents are talking about, then you got to start thinking whether we should take a different course. So where should we be and when? The literature is going to help you set that up. And if you're dealing with comorbid conditions, you're probably more likely to be talking about additional sessions. CBIT is usually about 10 sessions, and then you move on to boosters. But if I'm talking about comorbid ADHD and OCD and depressive symptoms and/or, I'm already thinking in the back of my head, I'm looking more at 15 sessions than I am in 10. So I want to keep that stuff in mind as well as I go. So some common misconceptions about these co-occurring disorders, which I thought it was important to discuss. First off is when you provide that feedback at the diagnostic session, sometimes kids they're sitting there counting, and one kid recently said, "I have 4 disorders? That must be terrible." And I had to basically take down some of the walls of the diagnostic walls to help that kid feel better about it. So, and I used a quote that my mentor John March taught me a long time ago, which is that the brain doesn't really care about our categories. We can call these things different categories of things, but the reality is they're all pretty interwoven, and we want to really make a decision on treatment for you that's going to take those things into account. And we're not going to be afraid to take this on, even though there are different numbers of diagnoses. That's not going to keep us from doing what's best for you. So you want to infuse some hope about that when you're talking about that. Another common misconception is that tics should always be the primary target. The reality is there's a number of studies suggesting that the comorbidity, the co-occurring disorders, are often driving functional impairment more than the tics. And if that's the case, the kid has tics, but they also have OCD that's leading to them being unable to finish their homework and getting behind in school, I may well want to go and say, let's treat the OCD first. We have a treatment that works pretty well for that, and we can come back to the tics after we're done. So I don't want to make an assumption that just because that kid has a diagnosis of tics that's going to be the main treatment target. It depends on everything else that's going on and how those things are going to interfere with or not interfere with the intervention I'm trying to do. I think another important issue is complexity necessarily compromises outcome. That there's actually a mixed bag in the literature. Sometimes the comorbidities are, when you have more comorbidity, you see compromised outcome, and sometimes you don't. And I think if you're doing a fully informed assessment and you're taking everything into consideration clinically when you're making decisions about treatment, you may be less likely to see the complexity compromising outcome. Because in randomized trials, you don't have that kind of flexibility, whereas in clinical practice, you can deviate, you can back up, you can add sessions, and so that may help you to avoid the pitfalls that complexity can bring. Another issue here, which comes up a lot, which is this notion that ADHD medications cannot be used if the patient has tics. And I think the issue there is that really puts you in a tough position as a treatment provider, because you may well recommend an ADHD medication for a kid who's got primary or pretty severe ADHD. And there's a lot of reluctance to start a course of a psychostimulant because of the fear that it might exacerbate tics. And the reality is, from the literature, is it might, but it also might not. And you can be fully informed clinically if you think those two are co-occurring and they're co-primary. You can use the literature to guide you as to what your first medication choice might be, and you can go slow, perhaps going up the titration schedule being a little lower on the medicine to make sure you're not having exacerbations. But the clinical reality is that leaving ADHD untreated over the long haul is probably going to be even more compromising to adult functioning than leaving tics untreated. So I think we don't want to be as shying away necessarily from that if we don't have evidence in a particular kid that these ADHD meds are going to make the tics worse. And if they do make the tics worse, I've got a behavioral intervention that may work anyway, which is teaching the kid how to deal with those worsening tics by doing CBIT. So I don't want to just automatically steer clear of treating ADHD if I have a kid with tics. I think that the bottom line is that all these misconceptions can undermine hope, and we don't want to undermine hope when we're trying to make a treatment plan for a complex presentation. We want to feel like we can manage it. We've done this before. We're going to help you with this as best we can. We're going to be fully informed as we go. We're going to be checking in to make sure we are where we need to be clinically, and we're not going to be dissuaded from trying to help you because you have comorbid processes going on. We just don't want to contribute to the sense of pessimism that can sometimes compromise involvement and motivation and compliance with the both behavioral and even pharmacotherapies. The interventions that we may choose can be compromised by people feeling it's not going to work. So I don't want people walking out of my intervention feeling like this is too difficult, it's too much, there's too many things going on. And I want to make sure I'm making that as clear as I can when I'm talking with families. And I believe we're a little, maybe 3 minutes over, but I'm at the point where I'm ready for questions and answers.
All right. Thank you so much, Dr. Franklin, for a great presentation. And actually, this was particularly relevant given that it's ADHD Awareness Month, and we're also just coming off of OCD Awareness Week. So thank you.
Oh, yeah, sure.
We've had a few questions come in so far, and actually the first one relates to sort of the last slide that you had. My child has ADHD, and he has started ticking shortly after he started on a stimulant. Did the medication cause his tics, and should we stop using the stimulant?
Well, I don't want to practice beyond the scope of my license, but what I would say is this: that ADHD and tic onset are often at around the same time. Usually, you see them younger than you see some of these other conditions. And so we don't know in that situation whether the tic onset is a result of the medication or whether it's something that would have occurred anyway. And given that 50 or 70% of the kids we see with tics also have ADHD, it wouldn't be terribly surprising. But one thing you would go and do is you would let the treatment provider, hopefully a child and adolescent psychiatrist, you let that treatment provider know And then I would rely on their knowledge of this literature. You know, are they using a medication that's more likely to be associated with tic co-occurrence? Are they using a medication at a higher dose than they may need? I mean, there's a number of things they can take into consideration to modify the plan. But I wouldn't necessarily think I have enough information to say for sure that one caused the other. But in the context, if the tics are coming up, and especially if the tics are bothersome to the kid, I want to feed that back to the psychiatrist or medication provider so they can take that into account when they make their next set of decisions about treatment.
Thank you. So the next question that came up, how commonly comorbid is depression in adults with TS?
Likely to be more common of a co-occurrence in adults than it is in kids. In kids, it's probably 10%. My guess is, in the studies I've seen, it's probably more like 20 in adults. And I would imagine, too, that you would also see a severity relationship there. So if the tics are so impairing the person's having trouble working or going to school, you may well see the secondary depression grow around that dysfunction. Which then, again, even if we think that depression's secondary to tic impairment, because sometimes it is and sometimes it's not, if it's secondary to tic impairment, that still doesn't mean we should just treat the tics. We've got somebody now whose depression is getting in the way of them either participating in treatment or doing other things that they need to do and would like to do. We're going to need to again, circle back to the treatment provider and say, all right, so now I'm feeling pretty depressed on top of these tics. How are we going to take that into account? And sometimes it's a medication decision, sometimes it's a additional pharmacotherapy option, or sometimes it's an additional psychotherapy option. But you want your treatment providers to have as much information as they can when they're making decisions, even if that's a change in functioning over time. You may have started out without having depression be in the way. We see this a fair amount, and then all of a sudden somebody starts slipping into a major depressive episode. Then as a treatment provider, even if you were starting out treating tics or OCD primarily, you've got to move and orient to what you're seeing there.
Thank you, Dr. Franklin. So the next question that we have is, what if the child doesn't feel any of the urges that supposedly come before the tics? What if the child doesn't even know they're ticking? Could CBIT even work in that case?
Yeah, that's a fantastic question. And here's what I would say about that, is I'd say it doesn't necessarily mean you can't do CBIT, but you're going to have to do CBIT differently. So instead of relying on the physical feeling that the person's noticing, you may well have to rely on some contextual information. So when does the kid engage in tics? What situations? Is it in math class? Is it in the morning? Is it on weekends? Is it when sitting in the back of the car? So all of those things will provide you with some advanced warning. In some ways, it's analogous to what a lot of scientists in the U.S. Western states try to spend their lives doing, which is figuring out when tornadoes are going to form. Because even a few minutes can make a big difference in terms of saving lives with tornadoes. In the case of CBIT, I can still implement CBIT procedures once I'm seeing tics, but I prefer to implement this before all the horses are well into the field after the barn door has been opened. So I can make the intervention upon, so I ask them to do their competing responses when they notice they're ticking, rather than when they notice the urge. Or I can also say, I can do CBIT by saying, we know when you're stressed out, when you're about to go up to bat in baseball, when you're about to go into a class that's pretty tough for you. We know, based on our observations, you're more likely to be ticking in that circumstance, and so let's get our competing responses going even before we step in. It's a little bit indirect, and I do think that it's better and easier, certainly, if we have good knowledge. But another thing that happens over the course of doing CBIT, I've seen this with a number of cases, where the kid may start out with no knowledge. But when you're starting to clue them into the process, all of a sudden they begin to develop that knowledge because they're now more focused on whether they're ticking and when they're ticking. And they may well begin to develop during your treatment. some improved awareness of when the thing is coming. And we reinforce them for that, and we say, okay, so if you notice that feeling in the back of your neck, or you notice that feeling in your ankles, even before you start doing the tic, I want you to do your competing response. So push those feet into the floor and hold them there and for a minute and see how we do. So it's possible. It just makes it a little bit harder.
Great. So the next question we have, how would you suggest talking to the siblings of someone who suffers from tics and OCD?
Yeah, I think it would be absolutely imperative that you talk to them in some way. I think the blind eye approach just is not effective for these kids. My guess is you're probably better off having that discussion with when the kid with the symptoms is not present, having it at a nice moment, not having it in the middle of their fighting over the TV clicker, that kind of thing. Setting up a good time to talk. In my house, it's usually the car. So I bring kids along, and we drive around, and we get into all sorts of important stuff when we're trapped in the car. So you may want to do it that way, and I think you want to be very matter of fact. I don't think you want to say this is going to compromise his future. I don't think you want to say she's really going to suffer and struggle, so you have to treat her especially well. I think you want to give matter of fact information. This is what this is what it isn't. This is what we're doing about it. I realize he's sometimes really frustrating, and he's making noises in the back of the car when you like to sleep, that kind of thing. And some empathy for their circumstances is going to be important. And then just basically saying we're a team and we're going to figure this out together. And then leaving open the questions. I wouldn't get into the basal ganglia or all sorts of things if the kid is 7. But I certainly think that a kid will, if I open the door for questions, then I think I'm going to be in better shape to really find out what they care about. But I think the bottom line is I want to share the information. I don't think I want to do that necessarily with the kid sitting right there the first time. But then we have matter-of-fact conversations about it, and we incorporate it into our lives instead of making it shameful and secretive and something we can't talk about. Those elephants in the room, they never serve us well.
Great, that's a great suggestion. So one participant asked, how do you handle refusal of treatment in children with Tourette plus?
That's a good question too, and I'd say that in children with Tourette plus, and even in children with Tourette minus, I mean, we provide information to people about what the problem is upon intake, and what we think we can do about it. And if they're ambivalent about treatment, we talk to them about that ambivalence. If they're outright, flat-out refusing, then one of the things I think I want to be attending to is why that might be. So it could be they're just afraid it's not going to work, in which case we could provide some information about that. If they just don't feel like it, they don't think it's that big a deal. And a lot of times with tics, especially young, the kids are saying to the parents, yeah, I do this, but I don't care, and nobody else seems to care either. Why should I do this? And when I'm listening to that, my gut instinct is maybe they're right. Maybe I'm not, because what I don't want to do is I don't want to drag them to the psychologist to do CBIT when they're overtly hostile to the idea. Because what I don't want to do is burn the bridge I'm standing on. But when I do see a kid who declines treatment, tic plus or tic minus, what I do see a kid who declines treatment, and I note at times that their functioning is impaired, that they missed out on something they wanted to do, they decide not to sign up for a sport that would have involved a lot of sort of intense concentration because they're afraid their tics might come out in that circumstance. Those may be opportunities for teaching, and without rubbing it in their noses, but saying, I'm really sorry that happened to you, pal. It looked like that's something you wanted to do, and yet it seems like you're a little worried that the tics might come out. And get their feedback on that, and then if they say, yeah, that was a problem, then I could also sort of say, well, completely up to you, sort of motivational interviewing 101, completely up to you, but there are places where they can teach us how to help out with it. So if you're interested in that, you circle back to me. I'm not going to make you do anything. But you can't make people do stuff. That's the bottom line, like it or not. And I think that certainly is the case with older kids. But one thing, you can hold feet to the fire. So if somebody's not functioning well, they have tics plus they have OCD, and they can't make it to school, or they can't finish their homework. You got to make sure that you're not accommodating to the point where the impact of that on the kid is not being realized. Because sometimes that impact, that regret of having missed out on something, can be the motivator for them to come back to it. There's an old Sheryl Crow lyric, which is, "There ain't nothing like regret to remind you you're alive." And sometimes there ain't nothing like regret to remind you need to do something about this. So I don't want to keep that away from them. It's an opportunity to move them, rather than drag them to the psychologist, because that's not going to work. And trust me, the psychologist is not going to be very happy with that approach.
Great, thank you. So the next question that we have, do you see sensory disorder in a lot of children with TS?
Oh yeah, I mean, for sure. That's certain sensitivity to sounds and tags and socks. You certainly see that kind of co-occurring with OCD, not just right OCD. Sometimes I can't tell the difference between that and tics. So you do see these sort of sensitivities, and you know, the world is impinging on them a little bit more than they would like. And misophonia is sometimes a more formal term for used for that, for sounds and chewing and that sort of thing. Yeah, you may see it. So the kids, sort of a heightened nervous system, if you will, to be broad about it. And so if you do see those things, and those things are driving the functional impairment, I can't go to the church picnic because there might be people there chewing. Then you know, there are interventions that you could use for that as well. But certainly not unlikely to see more kids with those sorts of issues who have comorbid Tourette's than without.
All right. So the next question we have, how important is it to have a mental health provider who specializes in TS and co-occurring behaviors?
Another good question. I would say this. I mean, and maybe this is a little bit of bias because I run a subspecialty lab, but I think knowledge of the primary disorder and the common comorbidities is going to make it more likely that you are going to get effective intervention. So to me, knowledge is power, and it doesn't necessarily mean age. It really means how much experience does this therapist have? Where do they train? Are they familiar with CBIT? Do they know anything about HRT? And I think making sure that I'm not in a place where we're going to primarily treat these conditions with relaxation or with other sort of anxiety, stress management interventions. Because the reality is that in the randomized controlled trials that we've been doing for the last 20 years, those are the control treatments. Now they may have a place in the intervention for some people, but as a treatment in and of themselves, and it's pretty common that they'd be offered for these sorts of conditions in community practice, they're probably, just from the standpoint of the literature, they're probably not going to be effective, which doesn't mean they won't be. But they're just estimating based on literature, they probably won't be. And so I want to put my kid in the best position I can to find the best, most expert people. And there's actually some really neat work that's happened in the last 5 years. Michael Himley, Doug Woods, they've done all sorts of really interesting stuff with a Skype-like system providing CBIT remotely. And what's really cool is so these are the world's experts, and they're providing CBIT via some fancy Skype camera, and lo and behold, they're getting outcomes in their interventions remotely that are comparable to what they're getting in person, which is really neat, because if you think about the disorder you may most want visual information in order to treat, it's tics. And so these cameras, they're probably better quality than Skype, certainly, but it raises the possibility that these experts can be made more available this way. And Michael Himley and Doug and Suzanne Mouton Odom are doing lots of interesting research now, looking at how to extend the reach of CBIT. So there may well be programs and interventions and tools and things you can have on your phone, apps I think they call them. I sound like I'm old. But things like that can make this treatment more accessible. I feel more comfortable with somebody who really knows these conditions and their interventions well. And if someone doesn't know what CBIT is, and they're my treatment provider for tics, I'm starting to worry that I'm not in the right place.
Thank you, Dr. Franklin. The next question we have is, TS is commonly misunderstood, particularly by school administrators who facilitate 504 eligibility meetings, and especially when a child with TS is doing well in school.
Yep.
Any recommendations for how to best convince or educate such a school so that the child gets accommodations they need at school so that the triggers are addressed to reduce anxiety, which worsens the tics, etc.?
Well, I have two answers to that. Answer number one is that we had a legal team come in here on Monday and talk to us about 504s versus IEPs. And these are lawyers who are expert in mental health issues and how they impact school. And the first thing the attorney said to us was, if you are eligible for a 504, in all likelihood you're eligible for an IEP. And the advantage of the IEP is it's enforceable. And whereas a 504 might be a number of recommendations. If the kid has something, a condition that's going to affect their ability to learn, which is what you need for point A, and point B, that you need to provide specialized instruction in order to help them, if that's in your 504, you're almost by definition, you're eligible for an IEP, which is more enforceable. So the first thing I would say is I would come fully informed. I want it, tics are a special issue too, because you've got, especially if you've got vocal tics, you may well have a reason that a kid's going to be removed from class that has not to do with their learning, it has to do with the learning of other people. So you've got to take those things into account. So I would say that educating the school district and offering to have somebody come in and do a little, either a webinar or do something for them to bring them fully on board would be helpful. We're actually doing something right now with the Chester County Intermediate Unit down here in the Pennsylvania area, where they brought us in to train their staff. And so we train them in identification and diagnosis, and we train them in CBIT. And now what we're doing, because one of the issues of access is the kid's busy, it's hard to get to a person who knows how to do CBIT. So we're bringing it to them. So they're getting CBIT in the context of their school day, which improves their compliance and improves their willingness to show up, etc., because they're skipping music to get it sometimes. And so we're in the position where we think this is such an important bridge. We're bringing our information to the schools. In the midst of that project, we're also bringing sort of more generally psychoeducation about tics to the schools. I think this is going to have to be done in a broader way over the course of the next decade, but individually, if you have a kid who has tics, you want to really take advantage of what the law provides you with the IEP if you're in a public school setting. And you want to take advantage of the opportunity to educate teachers and administrators about what to do and what not to do when helping a kid with tics. Having the kids simply leave the classroom, it's negatively reinforcing the tics. They get some relief from that the same way they would by doing the tic. And you wind up with a kid now who is not able to manage their symptoms in the context of trying to learn. That's not what you want.
Thank you, Dr. Franklin. So we just have time for a couple more questions. So the next question we have is, what is a good method to address OCD if that is a bigger issue than tics?
Yeah. I would say that the treatment of choice for obsessive compulsive disorder across the full developmental spectrum, young kids all the way out to adults, is a cognitive behavioral intervention known as exposure plus response prevention. And so if OCD is the primary condition, or I can't get a clean shot at the tics until I get the OCD out of the way, I'd want to find somebody who does exposure plus response prevention, ERP, you see it listed as sometimes.
All right.
Usually we're talking about 14 sessions over 12 weeks. We've tested this protocol over the last 30 years with adults and kids. Works in 5-year-olds, works in 70-year-olds, and it's probably your first option. And when you look at studies, pharmacotherapy studies that have compared pharmacotherapy options, usually SSRIs for OCD, comparing those to cognitive behavioral intervention, exposure response prevention versus combined treatment, really looks across the board, and there's many meta-analyses that have looked at this now, review papers, suggesting that your first line of intervention with OCD is not going to be a pharmacotherapy alone. It's going to be either pharmacotherapy plus ERP or ERP alone, if you can find it.
Thank you, Dr. Franklin. Next question we have, I know that medication is the recommended treatment for ADHD, but some parents will not consider medication in the first instance. What behavior management programs would you suggest for parents of a child with comorbid ADHD and TS?
Yeah, there are lots of behavioral protocols out there. I think that Russell Barkley has done some wonderful work on behavioral treatments for ADHD. Sometimes these are involving executive function training. Sometimes it's involving organizational processes. Sometimes it's involving teaching the kid to recognize when they're drifting and take more frequent breaks and those sorts of things. Collectively, it looks like those interventions can be effective, but we also know in perhaps maybe more so in ADHD than in OCD and probably even in Tourette's, it looks like there may be an advantage to the pharmacotherapy options alone when compared to behavior therapies alone for ADHD. So I think it will also depend on severity. If a kid's got a mild case and it's not getting behind in their schooling, then it might make sense to try some other behavioral interventions on top of trying to work on tics. But if I've got a kid who's failing school, and I've got a kid who's is irritating other kids to the point of having interpersonal problems, and they're getting suspended on a regular basis, I think the trepidation about medication is understandable. But if taking the medicine in that case worse than not taking the medicine, sometimes you have to conclude that it's not. And you want to be careful. You want to do it with an expert pharmacotherapist, but it may well be that there are some of these bridges you're going to have to cross based on how they're functioning, and if you're trying a behavioral intervention doesn't work, I'd be much more likely to move quickly to a pharmacotherapy option there. That's what the literature says. I'm not a pharmacotherapist, but that's what the literature tells us.
Thank you. So we have time for one more question. My 5-year-old has TS, symptoms of ODD, anxiety. At what age do symptoms of ADHD usually present itself? What are the things we should watch for the most at home?
Yeah, I think you'd be watching at home. You'd also be watching at school. I would expect that you'd see ADHD symptoms fairly soon if they're going to occur. And if I'm in the midst of already having ODD symptoms, and so suggesting some impulsivity, as well as tics, I may be looking for a behavioral specialist who can help me with both. And if we think anxiety is a big part of the oppositionality, we see that in OCD a lot, that the kid's not oppositional unless you make them confront something that makes them anxious, in which case I need to treat the anxiety disorder primarily. But if this is across situations and across multiple contexts, and not just with the parent but with everybody else, then I'm going to be looking for somebody who can help me with parent management training and behavioral interventions designed to reinforce the kid for doing good things and not just to focus on when they're getting out of control and not doing the things you're asking.
Dr. Franklin, thank you so much again for this wonderful presentation and for answering all the questions that came in tonight. So it's all the time that we have for our webinar. Once you leave the webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You'll also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. Additionally, the webinar will be posted on the Tourette Association YouTube channel for those who are unable to participate today. And we encourage you to reach out to us on social media about the webinar or other ideas and suggestions that you have. Again, we have a full-time information and referral staff who can answer your questions, as well as by emailing support@tourette.org or calling 1-888-4-TOURETTE, T-O-U-R-E-T. And on behalf of the Tourette Association, thank you again for joining us and taking the time to view our presentation. Thanks very much.
Good night, all.
Good night.